11. The mother of a 6-year-old boy is called to the school for a parent-teacher conference due to her son's erratic behavior. The teacher states that he often has a difficult time sitting still and is unable to stay on task while doing assignments. He does not raise his hand for questions and insists on interrupting his peers. She also informs the mother that much of the boy's homework is stuffed into his backpack without any organization. After many years of caring for children, the teacher states that his behavior is not typical of other 6-year-olds. Which of the following is the treatment of choice for the patient's condition? A. Discipline from the parents. B. Change of classroom environment with altered curriculum. C. Anti-epileptics. D. Psychostimulant. E. Psychotherapy. The correct answer is D. The case is one of attention deficit hyperactivity disorder, ADHD. This is characterized by at least 6 or more months of inattention, difficulty listening, disorganization, avoidance of tasks, losing objects needed to complete tasks, distractibility, and forgetfulness. At least some of the symptoms must occur before the age of 7. Typically, there are hyperactive and inattentive subtypes. In this particular case, the correct treatment of choice is a psychostimulant such as amphetamine or methylphenidate. Alpha agonists such as clonidine or guanfacine may also be used. Although structure and discipline can help organize behavior in children, it is important to recognize medical and psychological causes of behavioral dysfunction. There is nothing in the history that suggests a learning disability or cognitive decline for which a change in the curriculum is needed. Finally, although psychotherapy is important for comorbidities that can occur with ADHD, i.e. depression, this would not be the first treatment of choice. 12. A 6-year-old boy who had hypotonia at birth is brought to the neurologist for developmental delay. His mother notes that his eyes move abnormally, his head bobs, and he has weakness and incoordination in his legs. He has never walked like other children and is not performing well in school. There are 2 male cousins with similar symptoms but no affected female family members. On neurological examination, he has nystagmus, truncal titubation, and spasticity in the bilateral lower extremities. What is the most likely genetic abnormality in this patient? A. GFAP mutation. B. Deletion of PMP22. C. HTT mutation. D. PLP1 mutation. E. Mutation in FXN gene. The correct answer is D. This case is an example of Pelizaeus-Merzbacher disease, which is caused by a deleterious event, most often duplication, of the PLP gene. Clinically, Pelizaeus-Merzbacher presents with nystagmus, spasticity, athetosis, tremor, and ataxia. Typically, symptoms begin in the first 2 or 4 months of life. Given the X-linked pattern of heredity, this is a disease of males. Motor milestones are often delayed, and children frequently develop spastic quadriparesis. Cognition is also frequently impaired. Brain MRI commonly reveals diffuse leukodystrophy with increased signal intensity in bilateral hemispheres, cerebellum, and brainstem, which spares the U fibers. On pathology, there can also be islands of white matter, giving the sample a tigroid appearance. Management for Pelizaeus-Merzbacher is largely supportive. A GFAP mutation leads to Alexander disease and presents in an autosomal recessive fashion. The question stem suggests involvement in a male cousin with normal females in the family, suggesting an X-linked inheritance, typical of Pelizaeus. Merzbacher disease. In addition, Alexander disease of. The infant-child juvenile type usually has a frontal predominance of white matter change rather than the confluent nature of Pelizaeus-Merzbacher disease. A deletion in the PMP22 gene leads to hereditary neuropathy with liability for pressure palsies. A trinucleotide expansion of HTT leads to Huntington disease. A mutation in the FXN gene leads to Friedreich's ataxia, Pelizaeus-Merzbacher disease, caused by a duplication-inverted triplication, duplication in chromosomal segments including the PLP1 region. 13. A 9-year-old boy with short stature is developmentally delayed. He presents to the hospital in the setting of a gastrointestinal illness and has now developed acute blindness. A magnetic resonance image, MRI, of the DAS shows restricted diffusion in the parieto-occipital area bilaterally. His strength is normal and blood. Work is only notable for an elevated leukocyte count and elevated lactate. Which of the following is the most likely explanation? A. Kearns-Sayre syndrome. B. Leber hereditary optic neuropathy. C. Myoclonic epilepsy with ragged red fibers, MERV. D. Mitochondrial encephalomyopathy, lactic acidosis, and stroke-like episodes, MELAS, E-Lee disease. The correct answer is D. All of these diseases are mitochondrial in origin. MELAS is specifically implicated by the question STEM. Due to elevated lactic acid and restricted diffusion on MRI, Kearns-Sayre syndrome is a mitochondrial myopathy that nearly always occurs sporadically, thought to be related to somatic mutation in utero. Phenotypically, Kearns-Sayre syndrome results in progressive external ophthalmoplegia and pigmentary, retinopathy with additional risk of cardiac, abnormalities, sensorineural deafness or cerebellar, degeneration, Leber hereditary optic neuropathy results from a point mutation in mitochondrial DNA and causes progressive optic neuropathy and blindness. Patients may additionally have cardiac arrhythmias. MERV causes myoclonic epilepsy, cerebellar, dysfunction, myoclonus, short stature, and occasionally lactic acidosis. It is caused by a mutation in mitochondrial DNA encoding the lysine tRNA, LIA. Disease, subacute necrotizing encephalomyelopathy, is a mitochondrial syndrome that presents before 2 years of age with developmental delay, ataxia, failure to thrive, weakness, and ophthalmoplegia, which results from pyruvate dehydrogenase and cytochrome oxidase deficiency. 14. A 6-year-old boy has high arches and hammer toes. He begins to trip over his own feet. Examination reveals normal arm strength and sensation, but distal weakness and numbness in his legs, as well as a postural and action tremor in both hands. His nerve conduction and electromyography were abnormal both in his arms and legs, and a sural nerve biopsy was undertaken and is shown below. Which of the following was the most likely abnormality on his nerve? Conduction testing in his arms? A. Decreased motor unit action, potential amplitude. B. Decreased motor unit recruitment. C. Myotonia. D. Decreased sensory nerve action, potential amplitude. E. Decreased conduction velocity. The correct answer is E. The case and is demonstrative of Charcot-Marie tooth type 1, CMT1, a hereditary sensorimotor demyelinating neuropathy. Most cases are autosomal dominant related to duplication of the PMP22 gene. Symptoms vary widely, but include distal weakness and numbness that spreads over time as well as tremor in a large minority of patients. The electron microscopy image demonstrates several myelinated nerve axons with surrounding concentric Schwann cell proliferation, onion bulbs, as well as one abnormally Thin myelin sheath in the bottom left. The most common nerve conduction abnormality in CMT1 is slowed conduction velocity due to demyelination, although symptomatic regions with muscle weakness. And numbness may also show decreased compound, muscle action potential and sensory nerve action, potential amplitudes, as well as decreased motor unit. Recruitment, this would be less likely in the patients. Asymptomatic arms. 15. An 11-year-old boy is admitted to the hospital because of respiratory distress related to respiratory syncytial virus infection. While in the hospital, he develops progressive deterioration of his mental status and seizures. His examination shows obtundation, generalized dystonia, and mild orofacial dyskinesias. On laboratory evaluation, he has ketoacidosis, elevated, ammonia and hypoglycemia. Urine organic acids reveal elevated glutaric acid. A magnetic resonance. Image of his brain shows diffuse high T2 signal in the white matter, and imaging shows enlargement of the sylvian fissures and the cerebrospinal fluid spaces anterior to the temporal lobes, as well as increased signal intensity in the bilateral basal ganglia. Which of the following is not part of the possible treatment? A. Low-protein diet. B. Riboflavin. C. L-carnitine. D. Supplementation of lysine and tryptophan. E. Intravenous hydration. The correct answer is D, and the patient presented with a respiratory illness, accompanied by acute deterioration of his mental status. The diagnosis is consistent with organic acidemia, specifically glutaric acidemia type 1, GA1. This is caused by deficiency of the riboflavin-dependent glutaryl-CoA dehydrogenase, GCDH, which is a mitochondrial enzyme that converts glutaryl-CoA to crotonyl-CoA in the breakdown of lysine, hydroxylysine, and tryptophan. Clinically, patients typically present during an episode of illness with an acute metabolic decompensation characterized by ketoacidosis, elevated ammonia, hypoglycemia, and encephalopathy. Extraneous movements such as dystonia and dyskinesia of the mouth and face are seen. Some patients may have seizures or subdural hemorrhages, which may be confused with evidence of child abuse. Imaging shows enlargement of the sylvian fissures and the cerebrospinal fluid spaces anterior to the temporal lobes, as well as increased signal intensity in the bilateral basal ganglia. The diagnosis is confirmed by identification of elevated urinary concentrations of glutaric acid and 3-hydroxyglutaric acid. Treatment consists of withholding protein from the diet, intravenous hydration, and correction of metabolic derangements such as acidosis, hyperammonemia, hypoglycemia, and electrolyte abnormalities. Riboflavin and L-carnitine are also indicated. L-carnitine and a low-protein diet, coupled with an early diagnosis, help to promote normal development in children with GA1. In this case, the supplementation of lysine and tryptophan would worsen the condition, making this the incorrect answer. Choice.